Uh, Thanks to all my friends on the dais and my friends down here in front of me. Uh, I really cannot cover in 10 minutes time whatever I wish to cover, but let us continue this talk after this on various forums. I mean,
Is
the
it
idea.
audible, please? Is he audible there? Audio, can you adjust the mic
Hello.
volume?
Yeah, what I was trying to tell is that in 10 minutes time it's almost impossible to cover a very large topic like this, and we should form a forum. Uh, Raise it. Okay, thank you. This is necessary. Rising. So let us form a forum here and continue this discussion. I think that's what I would like to suggest. I'll quickly go through the processes. Processes to avoid TARS and infections can be at the patient level. Patient needs to be prepared well. Let me not go into details. Our operation theater structure and function both have to be under good care, good control. And our surgical team, as human beings who work in the operation theater, have to do excellent job, and they have to understand, and that has to come from the heart and not from monitored by somebody else. It's very difficult to achieve, especially in Indian scenario, but that's what we should aim at. So when I say patient preparedness, it starts a couple of days beforehand. What we do is, as soon as we diagnose a cataract in the outpatient department, but especially the lid scrubbing instructions are given to the patient then and there. Use either shampoo or anything else and keep cleaning the lid margins. He may undergo surgery 2 weeks later, but there is nothing harm. When we wash our face, usually the lid margins are not covered. So you can do it yourself, but then we don't scrub the lid margins. That specific instruction itself will reduce the oil slick that you find during the surgery, which is bad. Antibiotic profile. The other things I would like not to do, cover it up now. Betadine scrub is very important just before the surgery. As soon as the patient comes, he'll get antibiotic drops, dilatation drops, and once the surface anesthetized, we do put a betadine drop into the eye directly. It's commercially available, the 5% drops, and it's not irritable after, especially after you put it. Then that's and clinically examine the lid margins. You would have seen in the OPD a couple of days before, but examination just before, at least with the torch or little magnification on a slit lamp is very good. And OT transfer has certain protocols. Every hospital has got different ones, and that has to be looked at. So OT preparedness, monitoring sterility, that we will talk about it. Surgical team has to, everything has to come. You have to specifically take people who are good at it, who are honest and humble, not the people who show off. This is a selection process itself, it has to be different. Your street clothes, the clothes that we wear right now, walk around everywhere, will shred 1 crore particles every minute. It's shredding that much of thing. So whatever time you get into the operation theater, kindly change to the clean clothes and then only go. Surgery is over. Tomorrow we are going to get fumigation done in the OT, so we get inside with the clothes on, which are used outside is not permitted. Every entry, alcohol, hand rub should be there. Hand hygiene complication, every entry, door, you put alcohol and make it a habit to alcohol. All of us know. Sterile gloving and gowning again is very important. I'll have to rush through. Uh, these are things which you can take a photograph. Let me not cover it. And betadine scrubbing is very important. One of the key steps in surgical infection control protocol. This is something which you'll have to learn yourself and practice it. Good practice is to avoid the wrong patient, wrong eye being treated under somebody's name. This is possible only if the patient carries a case sheet everywhere. Patient or attendant has to carry a patient. There are at least 5-6 stations patient goes through before he gets discharged. The case sheet has to be accompanying the patient all the time. The staff should minimally move inside the operation unless you have a good AHU handling. AHU unit is there. Then movement has to be absolutely reduced. Double glowing in case of high risk surgeries. Timeout procedure. This is one of the important things that we practice. Before starting the surgery, announce the patient's name, all the conditions, medical conditions, and the medicines that he is taking, the right or left eye, and procedure confirmation, what surgery is being done. You may be doing a lid surgery, but then you may go and do an incision in the cornea, so that becomes a catastrophe. So any instrument that is contaminated, suspected to be contaminated, has to be thought as though it's contaminated and remove it and change it up. We have a practice where we don't use, we stock at least 3 months stock, and first purchase is first utilized, and only time tested party. Anybody trying to give samples to us, they try this out, they'll find dustbin. We don't use them. So store at least for about a month's time before use. That's the practice we use. It's in the hospital store for at least 1 month before it's utilized. So in case there is a contamination, it'll start showing the debris in the packs. Inspect against light like this, as well as in reflected light, and then you will pick up the particles. Don't shake it up, gently move it so that you see the particles moving around in case it's contaminated. Vacuum seal has to be seen. If the vacuum seal is released, it's unsterile. And never use galley part on the trolley. Store used packs. This is used one. We don't discard it. We put it in a plastic cover and label it and put it somewhere. And after 2 weeks, we'll discard. So in case there is a patient has a problem, we have something that is available with us for investigations. Check the label of the ampule. Many of them are very tiny ampules. They may be color coded, which we do not know. The print is so small, so wherever you kept the ampules, keep a magnifier so that you can magnify and identify the medicine. It's very important. And then always pour a drop of alcohol onto the top of the bunk there, and wait for 5 minutes time. The alcohol, you wipe it with a cotton swab. It doesn't become disinfected. You'll have to pour it like that, what you see there, and then wait for 5 minutes till it becomes dry, and then only you put a needle inside. This has to be for all xylocaine, Avastin, fibrin glue, whatever you use. That's the 80% alcohol is better than 100% alcohol. The ampules, we don't use it because the splinters could have gone inside. When you break it, the splinter has got a sterile surface and an unsterile surface. One splinter goes inside this. Out of 10 ampules in our study, 1 or 2 has got splinter inside. So what we do is we never use the ampules directly. It goes into the autoclave, and all the medicines, fortunately, that we use in ophthalmology are thermostable, and then on the table itself, we'll open and take it. In case splinter goes, then it's still safe. So these are practices. Always buy packs like that, which peel open type packs. Open it up. The person who gives, the hands are below. The person who picks up, the hand should be above. This is actually wrong, and tearing off also is wrong, and that's the right methods. And whenever you pipes, tubes and all come to the surgical table, at the entry side, you fix them with tapes. Otherwise, these tubes will go outside, become unsterile, and again you're going to drag them inside. The entire field becomes unsterile. Avoid using anything that is used already. This is a slide which I've been using for 15 years. Change all instruments, everything, every surgery, whether it's a gown or glove or instrument, whether it's a diathermy probe, whether it's a vitrectomy probe, phaco tubings, phaco tip, phaco sleeve. We have no business in reusing it, though the practice is something else in most of the hospitals. And buy equipment that are compatible for use. OT disinfection and cleaning procedures, there are a lot of videos available. Let me not spend a lot of time on that. Post-operative care is very important. Examination of the patient very next day is important. And hand hygiene, if you practice hand hygiene, wash your hands, sanitize them, and touch the eye, the patients are going to see and follow it at home. If you do it with an unsterile hand, patient will follow the same thing at home. So not only for maintaining the hygiene, but also to ensure that the patient follows these protocols at home, these are necessary. So that's the way all the instruments that are there should be on wheels, so that they're including the dustbin or microscope, everything, and including the OT table that you buy has to have casters so that it can be easily moved around, so that underneath that you want to clean it up. These are our operation theaters. We have 3 of them. They're all AHU controlled, and enough space should be there in the operation theatre. At least about 20 feet by 20 feet for one table is what is recommended and what we use. And it's possible to do it. These are AHUs. Today AHUs are miniaturized. They're not very small, but much smaller than the conventional ones. They can be hung under under the roof. If you have that, I'll just take 1 minute. Sir. I close. And these are the 3 operation theatres where we have AHUs. And it's a big science, and you'll have to take professional help in them. Everything that you have in the environment has to be controlled. Humidity and temperature has to be controlled. Humidity control is essential round the clock. Temperature, you can switch it off at the end of ACs, you can switch it off at the end of it. But see that you have standalone dehumidifiers like this, and see that the humidity is controlled between 40 and 50 throughout the night. So we have a reporting system wherein as soon as they enter, they have to tell me what is the humidity in the morning when somebody entered operation theatre. It should be around 40 to 50. If it is 60 and above, then there is a chance that microbial growth is happening throughout the night when you are not there. All the medicines should be kept and accessible. And audits are very important in any operation theatre. This contains all this small tray-like box. All the medicines are written there in alphabetical order. A is there and the Z is there. So it's very easy to pick up in case there is an emergency. Do not dirty the things thinking that it's going for cleanliness anyway. Bioburden has to be reduced. Monitoring of sterilization of instruments is a very big science, but that's a part of the SOPs that we have. Everything has to be written down like this. And post-operative OT processes, audits and analysis are a very big thing. What I would recommend is NABH, ECO, internal audit points are there, and this is very good. It's available free of cost. You can buy the book also from NABH. You may or may not enroll into NABH. We have taken the NABH assistance in a big way, and last 12 years we have been NABH accredited. We have gained a lot by that process. A lot of discussions are digitally circulating that NABH is that excess. It's not necessary, but ask me, NABH is absolutely essential to control or have a vigilance on what your hospital is doing. There's a lot of learning points that will bring safety to the practice that we are doing it. And it's available, and you follow the guidelines. Then you can apply and get the NABH clearance. Monitoring and reporting of infections, as been told, it's very important. We need to report at various levels. Internal audit is very important. This is where NABH audit points will come into role. We all should be able to trace a sterile pack at some point of time. See, you have autoclaved or UV2 sterilized, and your packs you have distributed to many places. And in case there is a problem, you'll have to trace all of them back. That's only possible when you have a recall mock drill is periodically performed. So again, you'll have to learn it through practice. And vendor evaluation. You may be buying so many things, but then you'll have to actually visit the store of vendor, see how he is maintaining it, how is the company. Wherever I go, I will go to the company and see how it's being manufactured. So vendor evaluation is absolutely important. Don't take his sales words into consideration. Your water, your air, the way you store in the hospital, the way you receive the goods. This is a very important thing. The moment anything comes to the hospital, see how it is packed, how it is kept, see how it is. See, this is a pack of drapes which has come to us, and obviously the inside drapes will be good, but then we'll miss out on contamination if you do it. So, friends, as the practitioners of ophthalmology, we have great responsibility towards the society, towards the patients, towards the individual eyes, and we need to be very vigilant of what we are doing so that we do justice to the work we are responsible for. Thank you so much.
I thank you, sir.